I volunteered to do this fireside chat, but really where it came from is I am a family doctor in the community. I will also do inpatient medicine and I practice obstetrics as well. And if you're my patient and you need palliative care in the community, I will do that as well. So I'm probably one of those old school family doctors that does a little bit of everything. I don't do the emergency room. That's the only thing that I don't do. But I think part of the impetus for me to sign up and do this is that I really found that when I was talking to people out in the community, that there wasn't a great understanding of some of the risks or like even some of the real benefits, but mostly the risks of alcohol and cannabis. So I thought this would be a worthwhile topic to do out in the community because I feel that there's a lot I think that people can learn about it. So my topic is how much is too much, and we're going to go over a little bit about alcohol and cannabis use guidelines, but also just go over some of the risks and what the current data shows too. So this is the slide that I opened up with. And the reason that I chose to open up with this slide in particular, which has a lot of information on it, the reason that I chose to open up with this slide is that I really feel like there's an underappreciation of what a safe limit of drinking is. I feel like there was this myth, this rumor, this piece of news maybe about 20 years ago that a glass of wine every night is really beneficial. That's something that I feel that a lot of my patients still hold on to. But I did want to discuss what are recommended amounts of alcohol, because I generally find when I'm talking to people that it's less than what people think it is. So this is what a standard drink is considered in Canada. It's obviously a different amount if it's a beer, cider, cooler, wine, or spirits. So that's what this is based on, is the definition of a standard drink, depending on what your drink of choice is. So when we're looking at some of the risks that we see with alcohol use, I think it occurs at a lot lower level than what people think. I find that when I'm talking to my patients and I'm telling them they're drinking too much, I think what they hear is, my doctor thinks that I'm an alcoholic. And that's really not the case. I think that what I'm trying to communicate to people is that you can drink enough to increase your risks of major disease without having a problem or having an alcohol use disorder. So when we talk about how much exactly that is, we are trying to define it by something that we call a risk threshold. And I'm really going to try to not get too in the weeds with this clinical terminology here. But basically, when we say we want our risk threshold to be 1 in 1,000, it's preventing 1 in 1,000 of premature deaths. So if we define it by a risk threshold of 1 in 100, it's no more than 6 drinks a week for everybody. So if you have one single drink every night, which is nowhere close to alcoholism, you're still drinking enough to harm your health. So greater than 7 drinks a week would be increasingly high risk. That, I think, is the bottom line that I'm trying to communicate. So exactly what are the risks of alcohol use? This is really something that I find is generally underappreciated. I think people will kind of appreciate that if I drink too much, it can be really hard on my liver. I think people are aware of that, but I find that people are generally not aware of some of the other risks. It is a big risk factor for multiple cancers. Oral, pharynx, larynx, I think a lot of people are not aware of that. Esophageal, that's a big one. I mean, if you ask any doctor what are the top 10 things that they never hope they get, that's probably going to be on it. Esophageal cancer is a horrible kind of cancer. Liver cancer, I think people are aware of, as well as colorectal cancers, which are pretty common. Risk of epilepsy with a lot of use, risk of stroke, risk of arrhythmias, which is heart rhythm disorders. So heart rhythms that are either the wrong rhythm or you're going too fast. Heart failure is a big one that I find that people are not cognizant of, is that it is a big factor in a certain kind of heart failure where the muscles just all stop working all at once. So I find that people are really not aware of that as a risk factor. And I find that even some of my patients that do have this kind of heart failure are really not aware of the role that continued alcohol use can play in the function of the heart muscle. This is a really big one that I find too. So many of my patients, if they come in and they have an unusually high blood pressure, my first question to them is, have you been drinking lately? Did you have a drink last night? Did you have a drink for a couple of nights? It will raise your blood pressure, and it can do it transiently over a week or two. So that is a really big factor for people. If they find that their blood pressure is elevated, they're asking me what can I do at home to try to bring it down, avoid going on medications. I will tell them avoid drinking. Liver disease, I think people are aware of. Pancreatitis, very, very painful. And actually, it's a big risk factor for dementia, too. I really wish that more people were aware of that, because I think that there's a lot of concern about dementia. And I think for anybody that's watched somebody go through it, they want to know, what can I do to try to preserve my memory as long as possible? So I would say limit your alcohol use. And particularly if somebody has any present memory issues, any alcohol use is really going to aggravate that, but it can actually cause dementia all on its own. So I don't want to delve too much into this, but I bring this up mainly because if I'm thinking about who I'm hoping to reach, it's maybe somebody that is wondering if they're drinking too much. Do they have a problem? Or maybe they have a family member or a friend that might drink a little bit too much or have a problem. So these are some of the ways that we are, as healthcare providers, would screen for a possible disorder. So one question is, in the past year, how often have you consumed more than 3 drinks for an adult woman or 4 drinks for an adult man on any one occasion? So this is screening for a particular type of drinking called binge drinking. And if it's ever in the past year, then there might be a problem there. One of the other questionnaires that we use, which I think people might be broadly familiar with, is this CAGE questionnaire. And the questions that we're using to ask are, do you ever feel like you should cut down on your drinking? Does anybody ever get annoyed at your drinking? Do you ever feel guilty about how much you drink? Or do you need an eye-opener the next morning? I think people are maybe broadly familiar with some of the pieces of that. So if there's 2 or more yes responses to any of those 4 questions, could be a problem. I threw up a lot of slides here, and I don't want anybody to get too lost in them, but I did want to speak a little bit about the phenomenon of alcohol withdrawal, because I think people are familiar with the idea of withdrawal, and I think people are familiar with the idea that withdrawal can be harmful, but I did want to touch on that a little bit, because withdrawal is a real syndrome of alcohol, and if somebody is a heavy drinker and they do stop drinking abruptly, it can be dangerous. So some of the symptoms can start, a day or so after the last drink, can peak around then, and then will usually resolve in about a week or so. A lot of the symptoms are, I use this word, autonomic hyperactivity, but it's like sweating, somebody's heart rate might be high, somebody's blood pressure might be high, they might be anxious, they might have tremors, insomnia, nausea, or vomiting. There might be some hallucinations present, and about 10% of people will have seizures, which can be life-threatening and can also cause people to seek out care. Some of the risk factors for withdrawal are if somebody has been through withdrawal before, that's what this kindling effect is referring to, or if somebody's had a history of severe withdrawal, including seizures or delirium tremens. Age will actually also put people at higher risk of developing complications from withdrawal or stopping alcohol abruptly. People that are over 65 might be more likely to have medical conditions. They might be drinkers for longer, or they might be more sensitive to medications, or they might be on medications that might make withdrawal a little bit more dangerous. So if people are mildly symptomatic, we basically just keep them comfortable. That's all this supportive care means. And that might be okay for the vast majority of people. But if somebody is symptomatic, we often will consider using medication to reduce the severity of withdrawal, because if somebody does go through a period of really high withdrawal, not only is that dangerous for them, but it'll make them more likely to relapse in the future too. So I did just want to highlight some of the resources in our community. So CMHA, Canadian Mental Health Services in Bracebridge, has a program called Rapid Access Addiction Medicine. So they provide a number of services, and they're probably the biggest touch point in our region for this. The services are offered in person and virtually. I've got a phone number there in case anybody wants to take it down. But they do a 1-hour phone intake session. They will offer counseling sessions, and they refer to a nurse practitioner in our area for medication management of withdrawal, which we may want to consider for some people. Some of the medications that we do use in the scenario of withdrawal, Some of them will use simply to alleviate some of the symptoms of withdrawal, but some of those same medications can actually be good to continue with after the period of withdrawal, too. So, some of these medications can reduce the cravings for alcohol, which I think can be really helpful. There's one in particular that we use really common that just really takes a lot of the fun out of it. So, it really blocks some of the euphoria that people will get with alcohol use. So, medications, I think there is a real role for that. Um, Usually, this is a short term program. And if anybody does require an in person detoxification, like if somebody's at a really high risk of withdrawal, either because they've been there before, they've got, maybe they're more complicated medically, there are detox centers in our area. The closest ones are Aurelia, Barrie, or North Bay. You would go through CMHA. The other way of doing it is if somebody shows up, like this is kind of the official pathway, but if somebody shows up in the emergency room, perhaps they require what we would call a Form 1 admission, which is an involuntary medical admission, then they might end up getting sent to a detoxification center first if they're a heavy drinker. So that's another pathway that people can get there. I did include some resources here. There's a lot of resources that you can find online. I think most people are familiar with Alcoholics Anonymous as a program. That is actually very well based in evidence. It does really seem to help a lot of people. There is something that may be a deterrent for some people. There is somewhat of a religious angle to it, but there is a secular almost version of it called the Smart Recovery. So that can be a good version for a lot of people too. Helpwithdrinking.ca I found to be a really good website. And then there's drug rehab services too. There's also a section there on alcohol. I did just want to point out some resources to provide culturally safe care, because we know that when we do provide care within that cultural context, people are more likely to actually follow through on quitting, and people tend to have a higher degree of success too. So anybody that has non-insured health benefits, you can actually be eligible for up to 22 weeks of counseling at no cost to you, which is great. There is a 24/7 helpline that can be available too. So I wanted to make that aware for people. Before I move on to cannabis, because I really didn't spend too much, I didn't want to spend too much time on alcohol. There is a slide that I wish I included in this that I am going to tell you about. And what I wish I included is, what about red wine? Because, because I do find that is, I think, where a lot of this one drink every night is good for me. Or I only have a drink of wine every night, and that's fine. Or maybe I have a drink or two of wine every night. So the red wine studies were all based on, I'm not going to say it right, it's resveratrol. I have a lot of trouble with that word. It's all based on resveratrol. And these studies came out almost 20 years ago. And what the study came out of is that people were noticing in the 80s in France that despite smoking like chimneys and having really high fat diets, eating a lot of really tasty things, that they didn't seem to have the same rates of heart disease as us. And why is that? So people started to think, well, they drink a lot of red wine. Could there be something in red wine that reduces rates of heart disease? And I think that's where a lot of this one drink every night of wine is good for me topic came from. So looking at the data on resveratrol, and looking at it 10 years later, in 2014, I found some studies. 2016, I found a really good review. Looking at the data of it, doesn't really seem to have been borne out. So there are actually isolates of resveratrol that people can take. People can take supplements of just resveratrol, but it doesn't really seem to have the effects that we wanted it to. And when we look at blood levels of resveratrol and urine levels of resveratrol, there doesn't really seem to be a correlation between that and heart disease. So one drink of red wine every night probably isn't as good for us as we really like it to be. I don't know. I don't know why the French people are still alive. Wish I knew. It might be because they walk everywhere. It might be because of different factors, but I don't know that it's from the red wine. Sorry. Darn. The next topic that I chose was cannabis, because I feel like, I don't know if everybody else gets the same feeling. I feel like since it became legal in 2018, it's become the panacea. It is the snake oil of choice. It is good for everything. It is good for what ails you. Grandma can use it for her arthritis. Take an edible. Oh yeah, there are certainly many fads that have come and gone, I think, but I think cannabis is, I don't want to say it's a little bit unique, but I think the legalization of cannabis has allowed us to collect a lot more data in the last 5 years than we've been able to reliably collect beforehand. Yeah. Well, and we're going to come across a lot of that actually, because, as you know, our biggest neighbor to the south, the US, like obviously we would get a lot of our medical data from them. And since it's broadly illegal in the US, there's not a lot of great studies that have been done. So we'll get a little bit into that. But that's a big, I think, limitation in cannabis thus far is that if something's illegal, you can't study it. So I did want to go into a little bit of composition and types of cannabis. So again, we're just kind of skimming the surface here. There's CBD and there's THC. Those are generally the two major components. And there's actually many different types of THCs in cannabis, many, many different types. But broadly speaking, CBD, non intoxicating, cannabidiol, THC. This is the part that gets you high. So that's what we know THC as. So there's been a lot of different types of cannabis, and there's been interest in a lot of different types of cannabis looking at different compositions. Like, well, what if we had a lot of CBD and a little bit of THC? What if we just take the THC out? What if we just take the CBD out? And there's been a lot of interest in that, I think. There's medical marijuana. And one thing I did want to touch on is that we've actually been using pharmaceutical or synthetic cannabinoids for a pretty long time in medicine, relatively speaking to the amount of time that marijuana has been legal. So, nabalone is a big one that has been featured in a lot of studies because it's been around a long time. Nabiximols, a little bit different. This is like a spray that has both components in it. The nabalone is actually a pretty cheap, relatively pharmaceutical. So when we talk about cannabinoids, a lot of the research that has been done on this nabalone, this synthetic or pharmaceutical cannabinoid. I only mentioned this one, like it's not available to us in Canada. I only mention it because it is also an old synthetic cannabinoid, so it's been more studied than other things. I've got a big chart here. Don't want anybody to get lost in the weeds of it, but the main thing that I really wanted to highlight for methods of ingestion is when effects could begin. Because I think that's where people get into a lot of trouble with it. If you're ingesting a little bit of cannabis and you wait a little bit, you don't feel anything, you ingest a little more, I think a lot of people get into trouble this way because when effects could begin could be anywhere from 30 minutes to 2 hours. And how many people are ingesting something and waiting a requisite 2 hours before they see what the effects it has on them are? So I think a lot of people will inadvertently ingest a lot more than they intend to and kind of get into trouble that way. Inhaling, generally pretty quick effects, last 2 to 4 hours. Topically, we don't really know. I will just include a little PSA here that this is our poison control number, and if you do ingest too much or have some odd effects or you're concerned about what you ingested, if you have your wits about you, you can call that and call 911 or go to your nearest hospital, and we'll go into that a little bit. Don't want to spend too much on this slide because I think people are broadly familiar with some of the effects on cannabis. It gets you high, but it really can vary. It can cause euphoria, relaxation, sedation. Some things I think people are not aware of is that it definitely can increase your heart rate. And there are certainly some people that go through it that have some psychosis as well, but we also know that it really does impair you. This is a slide I also really don't want to get lost in the weeds on. My husband would kill me if I didn't say that at least once throughout this presentation. But I mainly just wanted to highlight something that I think not a lot of people are aware of when they're inquiring about cannabis, is that there is the potential for a lot of drug-drug interactions. So think about, you can't have grapefruit with your Lipitor, that sort of thing. So when we look at some of the enzymes in the liver that break down cannabis, they also tend to break down a lot of other drugs. So we know what codeine and fentanyl are. That is a big heart medication. These are cholesterol medications. Warfarin, big blood thinner. These are some psychiatric medications. We could be less concerned about some of the antibiotics over here. But seizure medications, really things that you don't want to mess with the levels of. And it can mess with the levels in any way. So if we're looking at cannabis and what breaks down, you got this enzyme that'll do it, this one will do it, this is a whole different other one that will do it. And it can either boost blood levels of these drugs, reduce blood levels of these drugs, or change how they're metabolized. So I think there's a big question mark for how cannabis use and what kind of use affects what kind of drugs. So that's really what I wanted to point out on this slide. I do just want to spend a moment just on things that can influence my perspective, because I feel like when a lot of people inquire about cannabis or they're curious about cannabis, they might talk to friends, they might talk to neighbors, and, Joe or Karen down the street might say, oh, you should try this. It was really helpful for my arthritis. Or, oh, you're struggling to sleep. Why don't you should try some cannabis. You should smoke some pot. You should get high. And I think when people ask me about it, I'd really like them to understand what my perspective is as a physician. And what I mean by that is that, of course, I think I'm held to a little bit of a higher level than Joe or Karen down the street. I think people know that I am bound to give a little bit more of an evidence basis when I answer some of these questions. But when I answer this question, what I'm also answering is, what's the relative benefit to you and what is the relevant harm? Not only could this thing work, might it work for you, but is it better than other of the medications we use? Are there any harms to it that you need to consider? And how strong is the data that we have that surrounds it? If you're my patient and I tell you that you should be using something, I want to be able to know that I have the right evidence that tells me that you will actually benefit from it. So I think that this is where a lot of my perspective is influenced. And I think this is why people are kind of surprised at some of the answers that I end up giving when people ask me, could cannabis help with this? So when I answer them, I do try to take all those things in mind. So some of the way that I wanted to frame a little bit of the rest of this presentation is just addressing some of the common beliefs around cannabis or even common misconceptions. So first one, we'll talk about it. Cannabis is natural, so it must be harmless. I feel like this is probably the biggest one. So it's been about almost 7 years at this point since legalization. It was October 2018 when cannabis became legal. So this has really allowed us to say, what are some of the effects that legalization has had on our population? And I think this will kind of inform too, is cannabis actually harmless? And these were some of our objectives that we hope to achieve by legalizing. We wanted to make it safer. If people could have a regulated way to access it, they'd be less likely to get these unintended drugs as part of it. We wanted to keep the kids away from it. We wanted to reduce related crime. Those were some of the objectives. I think there were some other objectives too, but that was really, I think, a lot of the public health interest in legalizing it. So what have we seen? We've seen an increase in use broadly, not necessarily among daily users. So the daily users aren't smoking more, and it's actually a good thing. We actually don't think the kids are smoking more either. But there's more population of people that are using cannabis than there was before. And I think that's not surprising to anybody, really. We've seen a big uptick in emergency department use. We haven't seen a lot of necessary harms or changes, but a lot more emergency department use, 20% increase. That's kind of surprising, actually. That's an excellent question. And it's got a lot to do with some of the other things that cannabis can be associated with. But there's actually been, unfortunately, a threefold increase in children that are presenting with toxicity. That's bad. You think it's gummies. It's actually not. And people who manufacture gummies actually have to, there's some law that they have to make it not appealing to children. Like they can't make it look like candy, or they can't make it look appealing like candy, or package it like it's candy. Kids are actually, they're as likely to get into gummies as they are plants, flowers. It doesn't just have to be something that we think that could look like candy, but there is a threefold increase in children that are presenting with it. More people that are presenting with psychosis, people that are presenting with anxiety, unintentional overdoses. Pardon me? Yes, CHS. We're actually going to talk about that a bit because I do think not enough people know about it. We're actually seeing a lot of increased use in pregnancy too. So pregnancy use has doubled. Well, it's natural. It must be harmless. But it's so good for my nausea. I think that's where the thought process is I'm nauseous. We'll go into this a little bit too, but yeah. But this is the piece, is that alcohol is legal too. Yeah. So that we're seeing a lot of people using it in pregnancy. And I think some of that is it's good for my anxiety. It's good for my nausea. It's natural. It must be harmless. We're going to go into this. It's not harmless. There are some miscellaneous risks too. Like I think some people, probably a little bit more people are growing than they might otherwise be. And if you are growing plants, the law is no more than 4 plants. But if you are growing plants, you might have an increased moisture burden in the household, particularly with young plants. Canadian households don't tend to filter that out that well. There's electrical and fire considerations for some of this. And accidental ingestion. So if you have a plant, kids will get into that and they'll eat that too. They're not very smart. Impaired driving, there is obviously a risk of that. This is actually a big one that I was surprised at. There's increased risks of heart attack. I didn't know about that. I learned that. I don't have a reason for you why, but there is increased risk of heart attack. There has been some, again, it's the panacea, right? There has been some thought of could it be helpful in Parkinsonism? I didn't include that as a slide because that's not a common question that people have, but the short form is that we don't think it is. So is cannabis harmless? Well, there's all these related disorders here. Like, yeah, we know about cannabis intoxication, but cannabis withdrawal can be a real thing. So there is a real withdrawal syndrome associated with cannabis. Mostly psychological symptoms. You can have physical symptoms, can be less common. But there's a number of disorders that are listed in what we call the DSM-5. So that's like our psychiatric encyclopedia. Every psychiatric disease is in the DSM-5. So another one that I get really, really commonly is cannabis can help me with my pain. Karen and Joe down the street are telling you cannabis can help you with your pain. If you have pain, cannabis can help. Well, they might help with chronic pain, but we have to look at, do the benefits outweigh the risks? And this is where like my physician perspective comes into play, which is why I kind of prefaced all of this with things that I take into account when you ask me this as your physician. Do the benefits outweigh the risks? And importantly, is it better than what we already have in terms of medication? Like, does it outperform anything that we typically prescribe? So we actually don't really have good evidence for most subtypes of pain. So acute pain, you break your leg, that's acute pain. Acute is like within the past 2 weeks. Headaches, rheumatologic conditions like arthritis and back pain, not very good evidence that it outperforms what we already have in terms of medication. And I'm not saying that it can't do it. I'm saying that there's not very good evidence for it. And that's really part of the limitation of cannabis being illegal in probably America because there's so many more people there. They do so many more studies than we do. But also having been illegal in Canada for so long is we don't have a lot of evidence to say, yes, this is helpful. Could it be helpful with nerve pain? There is actually some evidence for that, but we think, A, the harms outweigh the benefits, And B, it doesn't really seem to outperform a lot of the medications we already have for nerve pain. So the suggestion is only to consider trying it if you've already tried 2 or 3 other things and they're not working. And it's actually the same recommendation for cancer pain. So again, there's been a limitation in the number of studies that are performed. And a lot of the studies that we reference when we're looking at evidence, they're looking at synthetic preparations, which I think is something else that really limits how we're able to give advice. Because if we're looking at doing studies, we're often comparing it head to head with drugs that we already have. And we want something that we can quantify, right? And if we have marijuana flowers, they can have really variable amounts of THC. Like commonly it's like 9 to 15%, but they're making strains that go up to 30%. So if you're just asking people, does smoking marijuana help with your pain? You want to know what kind of marijuana, what's the THC content, because that's really going to allow you to search a lot of the data on this. And a lot of the studies will look at synthetic preparation just because it's much easier to study. This is a big one. Cannabis can help with nausea and vomiting, and I think that's why people tend to reach for it in pregnancy. So that's a big belief that I think we see. And there's a reason for that. The original evidence that we have about that is about 30 years old, and it uses synthetic cannabinoids. And I think a lot of where this belief comes from is that 30 years ago, it was a lot more appealing than a lot of the drugs that we had then. We do have more drugs now than we did 30 years ago, and patients 30 years ago really seem to have much more of a preference for cannabis over some of the other drugs. So we actually would recommend against it for nausea and vomiting, which I think would surprise a lot of people, because I think that that's something that people are very much held on to the perception of, is that cannabis can help me with my nausea, or cannabis is good for chemo-related nausea or vomiting. It actually works similarly well to the medication that we conventionally use, but it can actually cause more side effects. And we don't have evidence to say that it's better than the other medications that we have right now. We think that it's possible that it can be useful in addition to other medications. In the review article that I was looking at, there was, I want to say 8 studies on this. 8. So in 3 studies, didn't look like it outperformed any of our current medication. In 3, might have outperformed it a little bit. In another, I think 2, it performed really, really well against our other medications. So again, even though this is a perception that people commonly have, I think this is something that warrants a lot more study before we can say, yes, you should use it for your nausea and vomiting related to your chemotherapy. What about pregnancy? So pregnancy, cannabis use in pregnancy doesn't really seem to have a lot of maternal effects, but there is a lot of concern about the effects of in utero exposure. And some of this isn't terribly surprising. We know that smoking is associated with low birth weights. If you're smoking cannabis, it stands to reason that could be the same. It does increase risk of NICU admission. The concerning thing that I think that most people are not aware of is that it can actually have effects on cognitive function, may have effects of cognitive function, rates of substance abuse and delinquent behavior later in life. That's more of a correlation. So when we look at what babies are exposed to in the womb, if cannabis is one of those things, they might be more likely to engage in substance abuse or delinquent behavior, but there could be other reasons for that correlation too. But I think that that's concerning enough personally to try to avoid it, and to try to advise my patients to avoid it too. Give yourself an easy child. One thing that I think is concerning that people are also not aware of is that it is fat soluble. It will actually appear in breast milk at higher concentrations than in blood. So you might be a certain level of high and your baby might be higher than you. I think people are often not aware of that. This I actually didn't know about as an obstetrician. It decreases concentration of major antibodies in breast milk, which I don't want to say it's the point, but it's certainly one of the points. So this is that CHS you were referring to. And I want everybody to know about this, because I think a lot of people don't know about it. And I actually find that it's under-recognized in the emergency room too. So this is cannabinoid hyperemesis syndrome, and it is a little bit of a mystery to exactly how this comes about. But we see it in daily, regular users of cannabis. It's a cyclic vomiting syndrome accompanied with abdominal pain, nausea, repeated severe bouts of vomiting. It is miserable. It is miserable, and people will end up in the emergency room with it. That is one of the things, you're right, that has increased rates of emergency room presentation. And I often see it go undiagnosed because emergency room, they're going to order some blood work, they're going to do an ultrasound, and none of this will show up. Unless they know to order marijuana levels in blood, they're not going to pick up on this. Unless they know to ask, hey, by chance, could you be a daily smoker of cannabis? This isn't going to show up. It is poorly understood about why people get this syndrome, but we think might be due to a buildup of metabolites in the blood. So THC is fat soluble. We think there could be some metabolites that build up over time that contribute to this, but it can actually persist for weeks beyond stopping. So I do wish more people knew about this. The other thing is I think because this perception that cannabis helps with my nausea and vomiting is so strong in people don't believe that it could be a cause of it. I often find that when I suggest to people that this could be the cause of their nausea and vomiting, they really don't believe me. 13-fold increase. So went from 0.26 in 100,000 people to 3.43 in 100,000 people in monthly rates of emergency department presentations. So actual number is probably not that much higher, but certainly much more common than it used to be. So this is a big one, I think. Cannabis can help me with my anxiety. Chills me out. Can help with my anxiety. You probably know where I'm going with this. It doesn't, we think. So even outside of this cannabis-induced anxiety disorder, which is listed in the DSM-5, which will actually present as anxiety or panic attacks, it does account for a large percentage of ER admissions, and even looking at it therapeutically for anxiety doesn't seem like it. We just don't have a lot of evidence that it improves anxiety in anybody. But I do think that that's a big reason for use in a lot of people. And again, we have to look at, is it better than the anxiety drugs that we already have? Not that we know of. It's a good one. Cannabis is not addictive. Another, I think, really common belief. Well, we think it is. This is a very common disorder that's listed in the DSM-5 as well as cannabis use disorder. So it can have a lot of the same features, I think, as alcohol use disorder. And I think that you could probably substitute cannabis for alcohol in all of these criteria and probably come up with something really similar. But it's the same sort of idea where people continue using despite negative outcomes, can be a chronic condition that people have trouble stopping permanently. The core feature is the loss of control over cannabis use. So any two of the following list here over a 12-month period would be positive for cannabis use disorder. And again, don't want to get too into the weeds here about how you diagnose it. So this is another one. Cannabis can help me sleep. Well, it might help with sleep. THC is associated with changes in slow wave sleep, which is the type of sleep that can be affected by learning or memory. And it actually, at low doses, might decrease the amount of time it takes you to fall asleep. Weirdly enough, at high doses, seems to take longer. So we actually think it might improve short-term sleep outcomes in patients with sleep apnea, fibromyalgia, chronic pain, or MS. Again, you could probably put this on any slide. We need to test it more. There is actually this decreasing time to falling asleep at low doses. That actually kind of seems to go away among regular users. So it might not be good to take every night, unlike any one of the 100 other sleep medications that we use. And I do just want to mention that cannabis withdrawal can produce this cannabis-induced sleep disorder, which is in the DSM. So how helpful is this thing with sleep that can actually produce a disorder related with sleep? Probably not that great. This is a really common belief, I think. You can't overdose on cannabis. So I went into the literature and I asked the literature, can you overdose on cannabis? Yeah, we actually don't think you can. It's been really hard to find even case studies, which is reports of single people that overdosed on only cannabis alone. I think this is part of the problem, is that a lot of people that come to negative outcomes from cannabis usually have something else in their system too. I did come across one case of one poor unfortunate man in Colorado who ingested, I forget if he smoked or ate, what ended up being 9 times the legal blood limit for driving of cannabis, and he jumped from a 4-story balcony. That was, I think, the only case that I could find where cannabis was listed as the cause of death. I did want to go over CBD oil, and I do just want to open the slide with saying that I am not recommending this book. But when I was looking for silly images to toss up on the slide, and I put in CBD oil and I looked at Google Images, I was like, this is why I'm doing this presentation. The CBD oil miracle. Manage pain, improve your mood, boost your brain, fight inflammation, clear your skin, strengthen your heart, and sleep better with the healing power of CBD oil. I am in no way recommending this book, but isn't that just the perfect encapsulation of everything that people think that cannabis can do now? So CBD oil, you're not surprised by now to hear me say that we have really limited evidence on it. As limited evidence as we have on the synthetic preparations that have been around for 30 years, we have less on smoked marijuana, we have less on THC, and we have even less on CBD oil. There are so few studies out there that have CBD oil or that have studied CBD oil. Could actually show some promise in seizure disorders, particularly in children. Maybe anxiety, maybe pain, maybe sleep. The evidence is so weak for it. So there's not a lot of good evidence on CBD oil at all. It does seem to have a really complex relationship with THC where it can affect the amount of THC that you absorb. So I do think that that's interesting. It's possible we'll learn a lot more about it as time goes on. But I think we also have to take into account how people are using it too. I know people use it topically a lot. People will ingest it. I think it'll be a long time before we really get some answers about whether CBD oil can be helpful with anything. Thank you for listening to my presentation. I think I timed it well. I've got about 10 minutes for questions or discussion.
What about smoking and lung cancer?
Oh, smoking and lung cancer, there's definitely an association there. Again, it's really hard to say what are the rates of lung cancer with smoking cannabis versus, or like how much cannabis. It's hard to dose depend that the way that you can alcohol because people ingest it in so many different ways. One of the slides that I was going to kind of throw up there is different ways to ingest it and all the different risks of it. Interestingly, there is, so, we're familiar with smoking cannabis. Of all the different methods of ingestion, there's vaping cannabis, and I think people are kind of familiar with like the e-cigarettes, like the Juuls. Like we've maybe seen those being sold in convenience stores. We've maybe seen other people using them. There is actually a particular syndrome of lung injury that we've appreciated with some of these e-cigarettes that are used. And part of the reason for that is that when we smoke something, we're smoking it and it becomes at a really high temperature. So there's all this toxic stuff that gets produced from this high temperature. The idea behind vaping is that it's at a much, I'm going way further into your question because I did look into this, but vaping became, I think, really hot. Again, pardon the pun. My husband won't kill me if I didn't include any puns. It became really hot because the idea of vaping is that you burn it at a lower temperature, less toxic junk. So that's the whole idea behind vaping. Yeah, it's supposed to be at a lower temperature. So e-cigarettes, again, oh my God, we could get so far into this. I really tried to avoid doing this when I was looking at things. But there's like different levels of sophistication with these e-cigarettes. E-cigarettes are all basically vaping, and the cheaper, like more disposable stuff, they don't temperature regulate that well when they ignite. So, you press a little button, you suck in, it doesn't temperature regulate that well. There are really sophisticated vaping machines that temperature regulate really well. So it's possible that those might not be as harmful, but even some of the cheaper e-cigarettes can produce a lung injury, we think, because of the inconsistent temperature at which it burns. The other thing that I think we need to take into account is that, again, don't know how much you guys pick up on this when you're like at the gas station or whatever, but these e-cigarettes, these Juuls, these like things that the kids are smoking and whatever, they're flavored, right? Like there's flavor. It can taste like this, it can taste like that. that can be harmful in a lot of cases. And I think some people will kind of put this stuff together on the black market too. And who knows what other junk gets put in there. But there's been a real syndrome of cases of lung injury from people vaping. We haven't really quantified a lot of the risks for vaping for the same reason we haven't quantified a lot of the risks for cannabis, because we just haven't seen it happen around that long. But there's certainly a lot of evidence for ingesting cannabis in different ways and how it can produce lung injury. So I hope that answered your question a little bit. Yeah. Yep. Yes, Paul.
THC use along with psychotropic drugs or bipolar meds, combining the two, what are the risks from that?
Oh, very good question. I kind of want to go back like 20 slides, but I don't want to. So what are the risks of combining THC with some of these psychotropic medications? That actually wasn't that hard. So psychotropic medications here, again, like I didn't really mean for people to get really into this slide. Topiramate, that's a drug that can be used in bipolar disorder. Oxcarbazepine, that's another one. Where are some of the other ones? Scanning up. Some of the anti-epileptics we'll see in bipolar disorder. Carbamazepine you can see in bipolar disorder. And then where's the other one? Oh, there's an antipsychotic medication around here somewhere. It's up there. There is at least one antipsychotic medication that can interfere, or that THC can interfere with levels of. So can interfere with levels of these medications, either as, you'll see words here, again, don't want to get too much into it. You'll see words here like substrate, inhibitors, and inducers. And substrate is what the enzyme works on. Inhibitors mean, oh, it'll bind to the enzyme and it'll bump off the thing that it's metabolizing. And then there's inducers, which is different. It can bind to the enzyme and make it work even faster to break it down. So it can really mess with levels of all of those medications, in addition to in and of itself producing psychosis, which I think can worsen both those things, and also worsening anxiety too. So not great to smoke with either of those medications.
When someone has a psychotic episode after using cannabis, have you noted if there's a distinction between what first time use or multiple time use, or it's showing up in all?
I can't really speak to that, but I know that a big point of concern with cannabis, and I didn't reference this, there's a big point of concern with cannabis is that it is linked to development of schizophrenia. And when I say linked, like I mean like it's associated with it. I don't know that that's the purest association, because when do people tend to start smoking cannabis? Well, they might be a late teenager. They might be in their early 20s. When do males develop schizophrenia? Generally about the same time. So it's hard to say whether there's like how strong that association is. I don't think we fully teased it out. I think the other thing is too, when people develop schizophrenia, they don't necessarily just come up with a psychotic episode first. There's often some other symptoms that are much more subtle that arise first. And I think it's hard to tell if people will intentionally or unintentionally self-medicate those symptoms prior to experiencing their psychosis. So I don't think the relationship is terribly clear between the two, but there's certainly a concern that cannabis use can precipitate schizophrenia or psychosis. I hope that answered your question.
Some university students have mentioned the fact that mild cannabis use can enhance their ability to focus on the work that they're doing. In other words, it limits distraction.
I have not found that. I would suggest those students get evaluated for ADHD. Just a thought.
Maybe they're using it because of the fact that they have ADHD.
That's what I wonder, just like kind of off the top of my head, because that is the kind of thing that ADHD people who struggle with ADHD complain of, is there's too much outside noise, you can't filter it out. But yeah, I had not actually seen any evidence that speaks to that. I would be interested to see evidence that does speak to that. Yeah, me too.
Well, you know why there's not any evidence? Because marijuana is not made by big pharma. Anybody can grow it. So the only studies are really supported by big pharma, and if they are not going to make any money on it, they're not going to do a study on it, so we don't know.
The corollary to that too, though, is that anybody that's growing it or smoking something that somebody else has grown, or even smoking something that's been legal, it's just really hard to standardize that as a medication in a study.
Yeah, hence the reason I was in favor of legalizing it, because I thought it should be regulated and taxed.
Yeah.
You buy a can of beer, it says 5% alcohol. You know it's 5% alcohol.
That's true.
It's not like you bought it from somebody on the street and it might be 30, it might be 2.
Exactly. And you know what? I think that was a good objective is, I'm not trying to come out against cannabis or against legalization. I hope that that's not really like the take home part of this presentation. I do think that there's a lot of good things that came from it. And I do think that that's one of the good things is that people now can know definitively what it is they're getting if they are smoking something. I do think that was a positive but I think that one of the challenges of cannabis is that the push for legalization, the advocacy for legalization didn't come from physicians. It was the community, I think, that really advocated for legalization. And now it's being used like a drug or a pharmaceutical in a lot of these instances, like all these people that are reaching for the medical indications of cannabis. And we can't say that it works the same as a lot of drugs.
But you wouldn't as a physician. Yeah. You get your information, like the pharmaceutical reps come in and say, this is the study we've done on this and this and this, and this is what you can recommend to your patients in this amount and that sort of thing. I could go to my doctor and ask her for a medical prescription of marijuana, and she's not going to give it to me, and I wouldn't blame her. Because how would she know? Her profession's on the line. As a professional, I wouldn't do it.
Well, and I think there are some limitations there that don't come from the pharmaceutical companies. Like, I actually spend very little time with pharmaceutical reps on my day-to-day. Very, 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 very little time. Minority of my time with pharmaceutical reps. So I wouldn't say that I get a lot of my information from there, but I think a lot of it having been so historically illegal is that a lot of doctors are not comfortable talking about it, talking about the dosing, talking about the evidence, because we haven't been taught. We don't. Yeah, exactly. Yeah. Well, I mean, there have been studies, but they've all been on these synthetic cannabinoids that we've been able to, regulate much easier. The guideline, let me see here. I'm getting lost a little bit here. This clinical practice guideline. So I just kind of like copied and pasted the title of it. So this very aptly came out in February of 2018. And this was published in Canadian Family Physician. So if you talk to your family doctor and you're looking for, what's a good summation of some of the evidence that we have and, what do you recommend, doctor? This is what a lot of people, I think, are going to be referencing, because there was not a lot that came out as guidance for how we should be advising people prior to this. And you know what? There's not been a great deal of change in the last 7 years either, because 7 years is kind of a short amount of time when it comes to having studies organized, paid for, completed, summarized, and published. It takes years to do that. So yeah, a lot of doctors, I think, are not as comfortable with it as I might be. My husband works in cannabis.
So you have guidelines for alcohol. You say if you do so much, then there could increase risks. Do the same here for cannabis?
You know what? I did have a slide on it. And I cut it. I did have a slide on it and I cut it. Okay, I think I might have printed it out though. So CAMH, which I always get confused with CMHA. But CAMH is the Center for Addiction and Mental Health. That's the one that's like headquartered at Queen and Ossington in Toronto. They have a set of lower risk cannabis use guidelines. I don't even think I can read that. But there are lower risk cannabis use guidelines. I don't even think I can read what they are. I think number 1 is don't do it.
Well, they can say that for alcohol too.
Don't do it.
Yeah.
Yeah.
And cigarettes, don't do it. I mean, high fat foods, don't do it. Yeah. I mean, they could do that for everything.
Yeah, I think if I'm remembering what the 10 points were, don't do it, I think was number 1. Number 2 is ingesting is probably better than smoking for you. Probably. We don't really know, but ingesting is probably better than smoking for you. Yeah. Well, thank you all for coming out.
Thank you very much for a very informative presentation.